हाय पद्मा मैम, कैसे हैं?
हेलो, गुड
नमस्ते पद्मा जी।
इवनिंग। गुड इवनिंग
ओके।
सर। नमस्कार। हाउ आर यू सर? मैं
I'm
बढ़िया हूँ
fine,
मैम।
ma'am. How are you? Yes, ma'am. Welcome to Vivek.
Kalyan sir, I just spoke to Sunita madam. She said she will join sharp at 6. So do you want me to wait for 2 more minutes and then start the meeting?
Can we just call her once and then
Yeah,
start?
I'll just speak. I just spoke to her 6, 7 minutes back, sir.
Okay, I'll call her then once.
Yes, sir.
गुड इवनिंग सर।
हाय तरु दीदी, कैसे हैं?
कैसी हो?
बस
मैं
बढ़िया।
तुम्हारी आवाज भी आई थी तो, लेकिन
हाँ।
वहां पे कोई था तो इसलिए मैंने कहा
हाँ,
कि
पेशेंट। हाँ, दिस इज द टाइम। मैंने भी कहा कि मैं भी 5 मिनट में फ्री होके आई विल सी।
डॉक्टर शाह सर, नमस्ते। कैसे हैं आप?
नमस्ते तारू। गुड।
आई एम फाइन।
थैंक यू।
आपको बहुत दिनों बाद देखा, फिर अब AICOG में मिलेंगे।
हाँ जी डेफिनेटली।
सर आप तो पहुंच जाएंगे कौन से 13 को, 14 को? नहीं, 14 या 15 को?
आई एम रीचिंग ऑन 14 फर्स्ट डे। वी हैव अ मैनेजिंग कमिटी मीटिंग ना।
या सर आपको देख के वो इंस्पिरेशन होता है।
गुड। एट लीस्ट आई कैन इंस्पायर सम पीपल।
ओ सर, यू आर ऑलवेज इंस्पायरिंग ऑल ऑफ अस।
अच्छा। सुनीता, नमस्ते।
सुनीता मैम, नमस्ते। गुड इवनिंग।
ज्वाइन तो कर लिया मैम ने, लेकिन
Yes, madam has joined.
डॉक्टर कल्याण, हाउ आर यू?
Namaste Taru ma'am. How are you?
मी फाइन।
Thank you so much for joining.
ऑल द बेस्ट फॉर फर्दर। आपकी जितने भी एस्पिरेशंस हैं
Corona, Team Corona, can we go live with the introduction so that
ये तो अंडा
नमस्ते
फोड़
मैम,
देगा।
हाउ आर यू?
तो एक ही लगा है ना।
Yes, ma'am, we are live now.
तो एक तो अंडा फोड़
Yeah, madam.
और एक
can you
अंडा
start
फोड़
sharing the
और एक
slides,
बार
please?
की दवाई।
Yes, yes.
एक ही तो बार लिए।
A very warm welcome to all the esteemed faculty members of Rajasthan and the MP societies, including Jaipur, Rewa, and Bhopal. This is the 8th webinar series in the ECHO, that is Enhancing Care for Healthy Outcomes, which are focus webinars for obstetrician and gynecologists, tailored by none other than Dr. Kalyan Baramde, sir. And I am the coordinator and convener for the program, Dr. Monica Umbardhan. Before we start the program, let us evoke the blessings of Lord Almighty. Can we have the inauguration slide? It is our privilege that we have none other than Foxy President Dr. Sunita Tandulkar Madam, Dr. P.K. Shah Sir, past President of Foxy, and Dr. Kavita Singh Madam, President of MPOX, with us to grace the inauguration function. I would formally take the privilege to introduce Dr. Kalyan Baramde Sir, the Program Director. Sir is the President of IAGE currently, and he has been the past Chairperson of the Public Awareness Committee. He is also the Maharashtra State Vice President. Sir also has been actively involved in AMOX from 2016 to current. Sir has been the organizing chairperson of the AMOX 2022 at Aurangabad. We welcome you, sir, and I request you to please formally welcome this August gathering.
I welcome everyone for this WICO webinar series. This is the 8th chapter of this series. We are going in each states of India since last 2 months. I welcome President of Foxy, Dr. Sunita Tandulkar Madam as the chief guest, And I welcome Dr. P.K. Shah, sir, who is a guest of honor, with Dr. Kavita Singh, ma'am, who is the president of AMPOGS. This webinar series has been formulated for
Very nice.
normal OBGYNs who are working day to day in a routine OBGY practice. And I welcome all the dignitaries for this webinar series from Rajasthan and MP chapter of Foxy. Welcome all. Now I can have CV of Dr. Sunita madam so that I can
Kalyan, you
introduce.
don't need my CV, please. No CV, please. Corona
Okay,
team.
Dr.
Team
Sunita ma'am
Corona.
is the president of Foxy, past president of prestigious IAGE, and going to be
Team Corona, I better see all of them than having seen my own slide. Close down the CV.
okay. She's the president-elect of ISAR also, and with her guidance, we are conducting an activity called Eagle Project, and which has really revolutionized the practices and advances in gynec endoscopy, and all the postgraduate students are giving lot of blessing to madam as well as Foxy and IAG. It was her brainchild which has brought this to a Vatavraksha of all this small sapling which she bought in 4 years back. So I welcome Dr. Sunita madam, the visionary leader of Foxy, IAG and ISAR for this eco webinar series, and I request her to give words of wisdom and few
You
blessings.
forgot one important introduction, Kalyan.
MC.
No, the great friends and colleagues for years together. That is my introduction with you, Kalyan.
I'm
We
your
are-
student, ma'am.
No, yeah. Once, even to my fellows, I say, once you start practice, you are my friends and colleagues. So thank you so much. When Monica gave me a call, PK Shah sir, thank you. Lovely seeing you. And probably we'll be meeting again for Ayodhya.
Yes.
Monica, very good work you keep on doing, and Tanu and Taru and so many people around here. Kalyan, you are absolutely amazing. I never realized the way IAG, see, because I'm Foxy president, I was too busy with my Foxy, but still I was watching because IAG is the organization close to my heart. And I was just, watching what are they doing, and the amount of activities you have done, Kalyan, is fantastic. And what I have seen is you have taken your all young team leaders with you. So that's always good. When Monica gave me a call and webinar activity, I said, Kalyan ka kaun sa webinar eco? I never realized what is eco now. Cardiac eco kar raha hai, wo kya kar kya raha hai? And then when she sent me the flyer and I was seeing the enhancing the health, really loved the way we talk about enhancing care for healthy outcomes, and under that umbrella, anything you can discuss on this earth. So I really love this word. Probably you should keep this word for your next presidency. Kalyan, whichever organization you will preside, you will definitely work with sincerity, hard work, and more with the creative mind. You have taken 2 states with you and then discussing on that. It needs a huge efforts. To me, webinar is a huge efforts. This year, I don't have webinars in my Foxy. First thing is no webinars because our ICOG, our academic wing, is doing lot of webinars. Then it becomes confusing because Foxy works with 30 committee chairperson. It becomes bombarding. But the webinars which are dropping in from IAG, from your all own series, it's fantastic to listen to them. And you have Dr. PK Shah and Dr. Kavita Singh. What else you want? Fantastic. Thank you. My best wishes are always there with you, your team, with your work for everything. And to note this, Dr. PK Shah, we finished 125 Eagle projects.
Wow.
And IAG together. Yes. This is a IAG's project. Only because I was a president, I took a permission from IAG. एक साल मैं भी साथ काम करूँ क्या? Because this project is very close to my heart. And I felt with the Foxy platform, it will get a stronger and wider wings. And I think now Eagle हर घर घर में पहुंचा है, हर कॉलेज में पहुंचा है. And now IIG will take it further ahead without me and Kalyan. But the team IIG will work. So
Thank
thank
you so
you
much,
so
ma'am.
much.
Thank you so much. Because IIG membership has now reached to 5,200. And
Wow,
yes,
Mm.
very
and
good.
Foxy is around 55,000 or more than that. So it's tenfold more, is more accepted, and Madam has this idea of looping Eagle project in Foxy has revolutionized it, sir. And we have more than 4,000 gynecologists who has been touched by these activities. There are faculties who are more than 400. That's what is important, that Madam has given so much courage to these newer people who are teaching others. So it's a teacher of teachers now. And that's what is very important, touching the life of all gynecologists and all endoscopic surgeons. And today I am at Chhatrapati Sambhajinagar, where there's an international endometriosis conclave of IAG is going on. And looking at the surgeries where Horace Rahman and all those were doing, I felt that our Indians, like on one screen, Dr. Sanjay Patel was doing, and down with me was Dr. Vivek Salunke, Dr. Pandit Palaskar. We felt that we are at that level, and that is because of the foresight of past
Work.
presidents like P.K. Shah sir, Sunita madam, who has brought these youngsters at international level. And hats off to all the past presidents of IIG, and specifically Dr. Sunita ma'am for this Eagle project. Thank you, ma'am.
Thank you. Mainly now with Eagle project, we could involve endoscopic surgeon into Foxy. That was the biggest thing. But when you are talking about endometriosis, we got a very new technology at Ruby Hall, and probably first time in the world will be treating adenomyosis with the, this is highly integrated robotic MRI involving in it, and it's a focal
MRF.
point, and it's a very expensive
HIFU.
machineries. It's not a HIFU, sir. This is robotic.
Okay.
It is
Okay.
robotically
Wow.
integrated. MRI image get integrated into it. So this is the first time in Asia. Our machine yesterday arrived. Now I have a meeting with on Wednesday where I'm designing a special probes. We can work on a rectal endometrioma now. No more resection and anastomosis will be needed. We'll
Great.
be doing with these robotic arms. But at the same time, I'm thinking and extending it to the adenomyomas.
Great. Very good.
So
That's
this
great,
will
ma'am.
be adenomyoma treating will be first time in the world. Today we had an extensive meeting. See, science is evolving, how you use this. So the way we are treating rectal endometriosis will be completely revisited with these machineries. They are very expensive, but that's the advantage of being in Ruby Hall. Thank you. Thank you, dear. Thank you.
So after stem cell, it will be a Ruby all again taking a
Yeah.
lead in endometriosis. Congratulations for that, ma'am.
Thank you. Thank you.
Dr.
Thank
Monica.
you, ma'am. Thank you for the kind words and your support always. I have seen your dedication when we inaugurated the ward here at VM. For endoscopy, madam has donated an entire ward so that the students of VM Medical College can learn endoscopy. So I have seen the dedication and the precision and with every minute detail that she has seen in the ward. Thank you, ma'am.
That
Thank you
is
so
what
much.
I feel, sir. Giving is living. Paisa to aega rahega, your name given. But that is thanks to the dean. I never knew that the name will be given to the operation theatre. Today when the MR comes or the examiners, for example, I think I don't remember her name, Vidya Shayad from
Yes, ma'am.
Dharwad. She had
Vidya
come. She
Thodi.
said it was so amazing to see suddenly from nowhere in the ward when I went, the OT was labeled with your name. So I think इथे माझे कार जुळती.
Good.
Thank you so much, ma'am. Thank you for gracing the inauguration. And I would now take the privilege to introduce none other than Dr. P.K. Shah, sir, the teacher of teachers, who has been the past president of Foxy also. Sir
Enough.
has,
Monica,
yes,
enough.
sir. Sir, for your blessings, please.
I think very happy to be with you all. And Dr. Kalyan, thank you for having me for this webinar, making me a part of it. Monica, nice to see you everywhere in almost all webinars, literally. And it's nice to share this platform with our FOXI President, Dr. Sunita Tandulkar. We are all proud of her for whatever she has been doing. When she talked about Eagle project, I was very much there when she took over as president of IAG and when she discussed about Eagle. And the way Eagle has progressed, I really feel that all those people who are involved with it, they deserve a big pat on their back. Number two, it's again a nice thing to share this platform with Dr. Kavita Singh, who is also the guest of honor. And the topic which Dr. Taruchaya is going to talk on is going to be the micronutrients in pregnancy. And Dr. Kalyan Baramde is going to moderate a panel on IUI and IVF with almost 8 panelists from different cities of Madhya Pradesh. So it's nice to see that people have become active. And I thought once the conferences start, the webinars will go down. But as the elections keep coming, I see the number of webinars increasing. And that's a good sign because people who are in remote places can definitely be benefited by attending all these webinars. I thank Kalyan and I wish him all the very best for all his future activities and elections. And same thing, Monica, you've been wonderful. I've seen you in
Thank you,
different webinars and you're doing a great job and wish you all the very best. So thank you for
Thank you, sir.
having me. And I shall take your leave because I have to go to Kolkata. And when Monica called me up some half an hour back or more than that, I actually had forgotten totally about this webinar. But I got ready because I can't leave Kalyan and Monica and join Dr. Sunita Tandulkar. So great to have this webinar and keep continuing such webinars. People will be benefited. Thank you very much and all the best.
Thank you,
Thank
sir,
you.
for all your blessings. He's the past president of FOXI, IAG, and he's been instrumental in teaching today also. He has been to Latur twice in last year, taking lectures on different topics like anemia, ultrasound. So that's what a real teacher is, that he's active today also and moving all around country, because I had taken his appointment for a Goa conference, but he was already preoccupied. So that's what the real teacher means. Sir, thank
No
you
problem.
and pranam to you, sir. Thank you,
All
sir.
the best, Kalyan. I'm
Thank you,
going
sir.
to Kolkata. So I'm continuing my journey every week and I'm out of Bombay. All the best to you.
Thank you,
Chal.
sir.
Bye.
Thank you. Thank you, sir. Thank you.
Okay.
Yes. I request Dr. Monica Gupta, madam, to please introduce our next guest of honor, Dr. Kavita Singh, madam.
Thank you, Monica. It's my proud privilege to introduce Professor Kavita Ann Singh. She's a president of MPOC and she's a professor and dean. And he has received n number of awards, including. Ma'am, you have 20 publication and 40 index publication. Welcome you, ma'am. Your blessings.
सब क्या बोलूं मैं, सबसे पहले सबको नमस्ते, नमस्कार। और आई वुड से कि मोनिका और डॉक्टर कल्याण थोड़ा पहले भी याद दिलाते थे तो अच्छा था, बिकॉज आई वाज जस्ट वंडरिंग कि फॉर व्हाट आई एम गेस्ट ऑफ ऑनर. Just I got a phone call in the link and I've just joined in, but now when I gone through the brochure, I realized that three panelists are there from Madhya Pradesh, Shabana, Padma and Rekha. So thank you for, but I would look forward for a better communication and a reason for me being here as far as IAG is concerned. And after listening to Dr. Tandulkar and Dr. Shah, I'm really amazed to see the way the technology is moving ahead. But being a dean from a public tertiary care hospital, capital of Madhya Pradesh, that is Bhopal. I would like to know more from the organizers what you can do as far as the training and something free of cost which we can propose to the government and for the students who are learning here, because talent, whenever we talk of learning training, it should be economical also, so it should not be only for the
Yes, ma'am. Kavita, ma'am,
yeah.
I'd like to just add here. I am president of IAG right now, and we are conducting Eagle project. Every aspiring gynecologist should learn endoscopy, that is EAGLE, in which if your HOD permits us, we come to a medical college for a full day. We teach residents how to do a hysteroscopy and laparoscopy free of cost. All will be taken care by IAG and Foxy. So we'll contact February of next year. And that is what we are.
Laparoscopy, Dr. Kalyan, laparoscopy and hysteroscopy are already done
Yes,
here
ma'am.
in our college.
Now
So
we have
what
come up
next?
with a robotics courses which are there. Also, we have suturing courses, hands-on suturing courses, which are happening at IAG office. But people have to need to come to IAG office. We can make it free of cost for all your students. That is not an issue. But they have to come to Mumbai for at least one day, ma'am.
Yeah.
So, and another is robotic courses.
Absolutely fine. So you just keep in touch, and head of the department from Bhopal, OBGYN, Dr. Shabana is there.
Yes, ma'am.
So you can get
I'll
in touch
contact with Dr. Shabana. I'll give my number
yeah.
so that we
And as
can
a
coordinate it.
president of MPOX, I really appreciate your efforts. Just little communication gap. Suddenly, I got this phone in my office, so I was wondering where I said yes. So little
So
earlier
sorry
reminder
for the
would have.
delay from
Yeah,
our
no,
side, ma'am. So sorry.
it's okay. Absolutely, it doesn't make any difference. But I was a little less prepared, and but that was there. But my best wishes are all with you, and
Thank you
the
so much.
MPOX State Association is there with everyone who are doing good work in our country. God bless you. Thank you so much.
Thank you, Dr. Kavita, ma'am, for your all the words of blessings. And as a
Oh,
part of
I could see Monica also.
yes, we
Okay,
thought Monica, madam has given you all the inputs, but
नहीं नहीं मेरे पास कुछ खबर आया नहीं मोनिका को,
चलेगा,
आप थोड़ा डांट लगाओ वेबिनार के बाद
चलेगा. So
चलिए ठीक है
thank you, ma'am. Thank you for the words of blessing. Now over to Dr. Monica.
Thank you, Kavita ma'am. Thank you, PK Shah sir and Sunita ma'am for gracing the occasion. And I declare that the inauguration is now over. I request all of you to please support Dr. Kalyan Baramde sir in all his Foxy endeavors. He will be there for the Foxy Vice President of the West Zone. And I request Dr. Monica Gupta madam to please conduct the academic session now.
Thank you, Monica. Unfortunately, any of the chairperson has not joined. So I just request if Kavita ma'am can spare the time to become a chairperson in this session. Dr. Taru Chhaya is going to talk. Please put the CV of Dr. Taru. Ma'am, please.
Monica, only two lines.
Dr. Monica Singh also can be there.
Yes.
Monica, only 2 lines, please.
She's a very good, close friend of mine and very dedicated worker and never say no to anything. And her way of doing work is excellent, and I have learned a lot from you. I'm not reading all this, what titles you are having, what work you have done, but really from bottom of my heart, I invite you for a talk. Thank you.
Thank you so much. It's okay. Now, thanks to all, Monica and Monica.
Three Monicas.
And Monica, Monica Singh too, for giving me opportunity to speak on this unusually untouched topic of micronutrients in pregnancy, that is the backbone of healthy pregnancy and outcome, that is healthy babies. So I'm sharing my slides.
Please make, Didi, are you co-host? Okay, fine.
Yeah. It's okay?
Make it full screen. Full screen.
Yeah, but I have done full screen. It's okay for you?
Mm-hmm.
Yeah.
Right.
So, micronutrients in pregnancy. Mother and baby both are benefited by good nutrition during pregnancy, as these 9 months are window of opportunity. The power behind healthy pregnancy is micronutrients. What is healthy pregnancy? The foods eaten before and during pregnancy help prepare the body to support and the growth of the baby. Sensible eating gives a baby the best chance for a healthy beginning. Calories taken during pregnancy, they contain macro and micronutrients for proper growth of baby along with healthy body of the mother. Now question is, what is healthy meal and how much? So healthy meal is that includes all the food groups in diet: vegetables, milk, dairy foods, cereal and grains, meat, beans, eggs, fats and oils. How to assess that what is proper nutrition? We can assess by weight gain of mother, blood reports of the mother, and growth assessment of baby clinically and by sonography. So we should know what is the optimal weight gain during pregnancy. Optimal weight gain by according to BMI, we see याद रखने को बस 1 kg per month का gain हो, that is optimal. If the somebody is gaining less than that 0.5 per day or less than 0.2 per day, that is underweight. We should not gain more weight too. So what should we do in first trimester? A time of rapid cell division, that is organ development, in preparation for the demands of fetal growth that occur during first, second and third trimester. So by the 6 weeks, the baby size is only like a pea. And by 7 to 8 weeks, major organs are partly formed, amniotic sac like placenta. It's like a bean. So critical nutrition needed no extra calories. Only whatever we are eating daily, it's okay. In second trimester, baby starts to hear, sex organs start maturing, hair grows, baby can cough or have hiccups activity. So we need some calories, 340 kilocalories per day extra. Protein, iron, calcium, magnesium, vitamin B, omega-3 fatty acids for the brain development. In third trimester, most of the sex organs get matured. Brain cells are growing fast. Calcium is needed more for bone and tooth growth. So the nutrition needed is 450 kilocalories per day extra. Protein, iron, calcium, magnesium, omega-3 fatty acids. We have few macronutrients along with micronutrients. These are nutrients required in larger quantity. बड़ा बड़ा है तो macro, छोटा छोटा चाहिए तो micro है. Like proteins, carbohydrates and fats. Also fiber and water. So there are 5 macronutrients because energy is required to maintain maternal homeostasis while supporting fetal growth. And what are the micronutrients is the umbrella term used to represent essential vitamins and minerals required from the diet to sustain virtually all normal cellular and molecular functions. Cell signaling, motility, proliferation, differentiation, and apoptosis that regulated tissue growth, function, and homeostasis. So important nutrients are macro means protein, carbohydrate, fats, fiber, water, and micro are folic acid, iron, iodine, calcium, zinc, copper, selenium, magnesium, vitamin A, D, K, and others. Normally we get from our diet too. What happens when they are deficit? Micronutrient deficits in pregnancy outcome. See, folic acid is deficient, then we can have neural tube defects, Iron deficiency, anemia and hemorrhage, we can have iodine deficiency, we can have thyroid problems, cretinism. In calcium deficiency, we lead to PIH and can lead to eclampsia as well. Zinc deficiency, again anemia, low birth weight babies, anencephaly, neural tube defects. And vitamin A deficiency, vertical transmission of HIV, infant survival, maternal anemia, and infections. So proteins, now one by one I'm taking, but macronutrients I'm very summarized I'm taking. Benefits are energy. They're crucial for generalized fetal and placental growth, proper digestion, growth of maternal tissues. Means power of tissues comes from proteins. Building of breast, uterine tissue to support growing baby. Build DNA and special cells that make up immune system. So we need 60 to 100 grams per day. What are the source? In vegans and non-vegetarians. It's so easy in non-vegetarians, they can have eggs, meats, and fish, but in vegans, it's little difficult. Vegetarians, green vegetables, seeds, grains, and vegans, they don't eat milk. Then milk and dairy products they cannot take, so they have to take vegetables, seeds, grains, and chickpeas, etc. Quinoa is full of proteins. Next is carbohydrates, a great source of energy for mother and baby. They break down into simple sugars like glucose, which pass easily across placenta and provide energy. Recommendation is 175 to 200 grams per day. Source in vegetarians, whole grain, potatoes, sweet potatoes, arvi we commonly call, and it's very tasty also, brown rice, oatmeals, banana, cheese in junk food, corn. They are rich in carbohydrates. Eggs, sweets, meat, fish, seafood, they're all non-vegetarian diet which is rich in carbohydrate. Fats, energy up to 25% comes from fats for fetal growth and development, especially brain. Higher intake of saturated fats can lead to preeclampsia, GTM, and preterm delivery. We always recommend, please, low fat and low carb diet you have to take when we see the patient is of GDM or preeclampsia. What are the sources? Monosaturated fats are olive oil, avocados, nut oil, nut butter, ghee, and polysaturated fats like fish, sunflower oil, mayonnaise, egg yolk. And water is the most important for proper digestion. It helps in nutrient circulation in the body, maintains amniotic fluid, helps in detoxification. So recommendation is 2 to 3 liters per day. Normally when we ask our patients, they say, I drink a lot of water. How much? Then you have to ask glasses. Maximum 4 glasses, 5 glasses. Then we have to tell them at least 2 to 3 liters you need. Fiber, keeping the digestive system running smoothly. Important for healthy heart, decrease risk of diabetes and reduce risk of preeclampsia. Sources are fruits and berries, green vegetables, but don't peel them, grains and flakes. Now we coming to the topic, micronutrients deficit and pregnancy outcome is vitamin D deficiency will lead to neonatal hypocalcemia, vitamin K, hemorrhage. If the copper is deficient, patient can have anemia, baby can have anencephaly and low birth weight. In selenium deficiency, neural tube defects, brain dysfunction. With magnesium,
वो देख सकते हैं
development,
हाँ वो देव करो
toxemia.
कभी चेक करो फोन कर बुला दो साल अपना भाग
Iron deficiency, iron is needed for red blood cell production and anemia prevention. Fetal and placental requirements, expanded blood volume. The source rich in iron is spinach and iron fortified whole grain breads. Requirement is say 27 milligram per day. कोई भी आयरन टैबलेट्स हम प्रिस्क्राइब करें उससे पहले वी शुड सी कि हम उसमें कितना उसको अमाउंट दे रहे हैं, बिकॉज टोटल आयरन इज नॉट एब्जॉर्ब. 50% वेस्ट होगा, ओनली 50% में भी लेस, ओनली 30% इज एब्जॉर्ब. सो अगर हमने ऐसा आयरन दिया जिसमें ऑलरेडी 10 milligram per day है, तो there is no use. So these are iron rich foods. Next is folic acid, that is needed for blood and protein production, effective enzyme function, prevention of neural tube defects. Best sources are green vegetables and fortified breads. The daily requirement is 600 microgram per day. These are the foods which are rich in folate. भिंडी easily सब घर में खाते हैं. Cauliflower and papaya we don't give in pregnancy. I don't know why. Leafy green vegetables. Calcium and vitamin D3. Strong bones and teeth. Everybody want. Vitamin D3 is needed for the absorption of calcium. So best sources are calcium, milk, cheese, yogurt, spinach. Vitamin D source is sunlight and fortified foods. So the daily requirement of calcium is हमको याद कर लेना है by heart 1200 milligram per day. Vitamin D 200 units per day. Iodine needed for thyroid function and neurological development, mental. Best source of iodine is fortified salt. अपन को आजकल फैड है कि हम रॉक सॉल्ट खाएंगे या फिर दूसरे वैरायटी की सॉल्ट्स, बट द सॉल्ट दैट इज आयोडाइज्ड fortified with iodine is the best salt to eat. Zinc maximum 34 milligrams per day is needed for cell division, tissue growth in early pregnancy, to decrease preterm births and prolong labors. Best sources are non-vegetarian, poultry, red meat, oyster, fortified calcium. But in vegetarian diet, beans, nuts, whole grains, and dairy products are rich in zinc. Selenium and magnesium, they are also important for the GDM and preeclampsia and preterm labor, and magnesium for the same. Vitamin A is also needed, 800 microgram per day for embryonic growth during early pregnancy. Recommendation of milk is very good early pregnancy. They are rich source of vitamin A with green vegetables. Vitamin K, it's important in helping blood clot. It's not needed during pregnancy except those on anti-seizures medication, or there is risk of vitamin K deficiency in fetus. So oral vitamin K 10 milligram per day from 36 weeks until delivery. Metallozymes, these are more than 300 enzymes whose functions can be impacted if diet is deficient in manganese, zinc, magnesium and copper. अपन इन चार को याद कर ले कि भाई हमको ये खाने, तो वो अपने आप ऑटोमेटिकली दो enzymes are with us. They play a role in maternal gestational health and ensuring birth of healthy offspring. So what is the take-home message? Good nutrition during pregnancy is a boon for mother and baby both. Macronutrients are the source of energy, but micronutrients give organ-specific growth. Deficiency can lead to many issues like pregnancy loss, birth defects, and metabolic disturbances. Supplement of each nutrient is recommended for proper baby growth. Maternal undernutrition and obesity increases risk of pregnancy complications and future health. Westernization in diet adds to risk of imbalance and deficiencies, and also obesity epidemic. So mother health is equally important during pregnancy as well as during lactation. So a well-nourished mother is the first gift of a baby receives. Balanced nutrition before, during, and after pregnancy protects 2 generations, preventing deficiencies, reducing complications, and breaking the cycle of obesity. Thank you. I hope I finished in time.
Madam, it was a beautiful talk.
Thank you so much.
For the
Simplified, I think.
yes, for the first time, I enjoyed listening to nutritional therapy so much. And the way you presented it was very nice, systematic. The slides were very beautiful,
Thank you
and
so much.
congratulations, ma'am.
Anything anybody want to ask regarding this?
Madam, in the sources of carbohydrates in your slides, you have put sweets also and soft drinks also. So, won't our patients get a wrong message that if they have carbohydrates through
But they don't need much carbohydrates during pregnancy. That written also, because they're the only source of energy. Those who are already having good amount of nutrients, they don't need much of carbohydrates. Under nutrition mothers, they need, so they can eat anything because some energy they also need.
Yeah. So if it is an undernourished pregnant mother and she is recommended a proper traditional Indian sweets, it is not bad, no, ma'am? It is
Not
good
at all
for
bad, because see, we do not consider only those patients who are urbanized. They come to us because those who are in rural and doing very hard work whole day, even after their delivery, they are doing much work. So they need some nutrition also. So जैसे हमारे traditionally लड्डू खिलाते हैं, तो I तो advise please खाओ.
But they made laddu with a jaggery. Most of
हाँ,
the villages
जैगरी
they
है,
use
उसके
jaggery
अंदर
and that jaggery is
जैगरी
good.
है, और उसके अंदर वो बादाम डालेंगे, गोंद डालेंगे. They give good nutrition to the patient also, because lactation में
seeds,
भी हमको चाहिए. Otherwise lactation के अंदर it will be poor milk.
Cumin seeds and all, they will also somewhere help with all these things. And they use jaggery. Dr. Monica, here we use jaggery. Most of the villages, they use jaggery. They don't use proper salt, मतलब proper sugar, जो अपनी refined sugar होती है, वो नहीं होता है. तो वो that
अगर
is
मान
not
लो
that
कोई
harmful.
GDM का पेशेंट है या कुछ है, तो उनको अपन स्टीविया के साथ बोलेंगे आप ठीक है, डोंट गिव. तो ऐसा कोई एक ही चीज से अपन सबको नहीं डाल सकते. We can differentiate in diet according to the need of the patient.
In fact, jaggery is good and rich in iron also.
Iron also.
Jaggery is very good for the health.
If they make a chikki made up of jaggery and peanuts in an iron kadai, it is very good.
Here we have til ke laddu, sesame seeds. Sesame seeds are very good for the health.
कैल्शियम बहुत है ना. और अगर हम लोग कहते हैं जो भगवान जी के वो होते थे ना, गुड़ और चने का प्रसाद, तो वो गुड़ चना खाएंगे तो प्रोटीन्स एंड आयरन दोनों चीजें पूरे प्रेगनेंसी भर मिलेगी.
Yes, true. And we are gradually coming back to traditional foods. Even
I
the
think
youngsters.
any unrefined food is good. Directly taken from the source, we should
कोई
have.
खराब नहीं होता था, but only problem with the traditional food is की quantification. They don't know how much. वो बोले अजवाइन खिलानी, कितने खिलानी, I have to ask them. तो बोले इतनी सी का कोई मेजर नहीं है. They don't know the measure, क्योंकि बड़े बड़े कह गए हैं इसलिए they are giving. So उनके साइड इफेक्ट्स भी हो जाते हैं, like they tend to
Constipation is the most common one.
constipation and the piles. So हर चीज का एक क्वांटिफिकेशन इंपॉर्टेंट है. अगर हम लोग इसके ऊपर एक रिसर्च करने लगे कि वो जो ट्रेडिशनल फूड है उनको हमें कितना क्वांटिफिकेशन दे, तो इट विल बी वेरी गुड फॉर एवरीवन. आज के जनरेशन. डॉक्टर कल्याण, आपसे रिक्वेस्ट है इसके ऊपर कुछ करा लो.
Yes, madam. We'll do a research in some of the centers, and then we'll come to a conclusion about this.
Now, thank you, Dr. Monica, for being a chairperson in our session. Now, we proceed to our next well-awaited panel discussion, in which you are also a expert in that panel. and I request Kalyan sir to moderate it. Please put the CVs.
At the outset, I would like to thank Kalyan Bhai for giving me the opportunity. Kalyan sir, regards, and all our best wishes are with you, sir.
Same here, ma'am.
Dr. Desh Deepak is another expert in our panel, and he is from Kota, and he has joined. I'll just call him again. What happened? He has just logged out, and he was an organizing secretary of West Zone Yuva Foxy, which was an.
But I joined with the
Okay,
Apple,
okay.
my Apple mobile.
Okay,
I'm
okay,
here
okay.
only.
Okay, sir. Thank you, sir. Thank you. Welcome, sir. And he has done an excellent Kota conference with such a studied with stars and all. And that was a remarkable thing in Rajasthan. And in spite of his infertility and laparoscopy, he is much interested into high-risk pregnancy, BOH and USG. And he is a pioneer of advanced endoscopy and IVF in Kota, and his credit for first IVF baby and first ICSI baby of Kota region. Welcome you, sir. Dr. Monica Singh, very close friend of mine, working tremendously. She is having a synergy series of IAG and ISAR, and she is working endlessly, and we share the same name. She's a president-elect of Bhopal OBGY Society, former founder president of ISOPA Bhopal, vice president of Bhopal Menopausal Society,
Thank
and
you,
she
thank
has
you,
done
Monica.
tremendous work. Our panelists are next. Dr. Shabana. She's an organizing secretary of VPCon Foxy and presented many papers in national and international conferences and published many papers. Next. Dr. Purnima Tiwari, she couldn't join because of some emergency, and she is from Bhopal, and she is awardee of Foxy Traveling Fellowship and received Dr. Manish Bankekar Young Achievers Award Clinical in Annual ISAR Conference on 2024. Next. Dr. Padma Shukla, ma'am. She's a president of Reva OBGY Society, and she has received Jagveshwari Mishra Prize and C.S. Dawn Award. Next. Dr. Rekha Singhal. She's a secretary of Reva Society, and she has received n number of awards in Cervical Cancer Awareness Award, Dr. Dhuru Shah Trophy Award, Dr. Gangadharan and Chatra Award, and very close friend of mine. Next. Dr. Ritika Mathur, she is from a past president of Kota, and she was a treasurer in Kota West Zone Yuva Foxy, and she is a very good worker in the art of vaginal delivery and in the high-risk obstetrics. Next. Dr. Ishrat Jubair, she is worked in the Unique Hospital and Fertility Center Bhopal, and she is a professor at Chirayu Medical College Bhopal and founder treasurer of ISOPA Bhopal chapter. Next. Dr. Shilpa Dodani, she is a fellow of minimal access surgery, and she has done gynecology from MUHS Nasik and fellow in fetal medicine. Next. Dr. Nidhi Bhuturia, because of some emergency at her home, she won't be able to join, and she has won 5 gold medal in the MBBS and awarded with Shankar Dayal Sharma President Award for Best All-Rounder Student in the MBBS, and she was a past treasurer of Kota OBGY Society. Next. And over to Kalyan sir for the panel discussion.
Dr. Padma madam has joined.
Yes, sir. Padma ma'am was there.
I can't see her.
I think she has left. She was there.
Can you just call her so that?
I will just make a call.
Yeah. So basically we are going to talk more on IUI than IVF, and our panel discussion will be on topic of optimizing IUI and IVF results. So I suppose we have expert Dr. Desh Deepak and Monica Singh will be more comfortable with IVF because they are very well-known IVF consultants. So few of the questions, and at the end of each question, we'll ask experts to guide us.
So the base of every IVF specialist is IUI only.
Yeah, that's fine. But
IUI
I got message that few of them are not doing IVFs.
मेरी
So
बनाओ कि वैसे
this
बना, बस
question
शक्कर
is
नहीं डाल
guided to you. Yeah. A 32-year-old couple have been keen to conceive since last 2 years. And normal pelvic ultrasound. So my question, would IUI be a benefit for this couple? We'll start with Dr. Rekha, please.
Yes, this case is, I think this is an unexplained infertility. To some extent, we can increase pregnancy rate with IUI.
Okay. You want to do any test before going to IUI, or you will directly go to IUI, madam?
Yes, we can go for a tubal patency test.
Right, tubal patency test. So, Dr. Rekha, madam, what all tubal patency test we can offer to this couple?
Hysteroscopy, hysterosalpingography.
HSG or hysterolaparoscopy, you mean to say? So,
Both.
yeah, both, or if HSG is normal and 3D ultrasound is good, suggestive of normal spillage. Sometimes you can do a sonosalpingography, which is suggestive of good spillage. Then we can go ahead. If there are no history of PID, tuberculosis, then we can go ahead with the IUI. And if not, then we can go for a hysterolaparoscopy. So IUI versus intercourse. In unstimulated cycles of couples with unexplained infertility, this RCT has shown that with unstimulated cycle, the IUI success rate is around 4%, and with only time intercourse is 2.4%. There is little evidence to assess IUI in unstimulated cycles. So patient selection is very important. What are the clinical situations where you recommend IUI? This question is for Dr. Ritika Mathur. Dr. Ritika, you are there?
She's there. Please unmute. Dr. Ritika, please unmute yourself. You are muted. Ritika? I've called her, sir. She's there.
So you can call her
Hello,
once more.
Dee. हाँ,
She's,
yes,
अब
yes.
आ गया आवाज। She's there, sir.
Dee, can I pass this question because मेरे अभी थोड़ा सिग्नल का प्रॉब्लम हो रहा था, तो अब मैं कनेक्ट हो पाई हूँ.
Dr. Ishrat Jubair, can you just take this? What are the clinical situations where you recommend IUI?
Yeah. Okay. Basically, IUI definitely it is recommended in cases of male factor, like where the mild to moderate sperm parameters abnormality, and there is a coital difficulties are there, and unexplained infertility, and mild degree of some endometriosis is there. So IUI would work better in these cases.
Okay, what Dr. Ishrat madam has told rightly. There are any non-medical indication for IUI which exists, madam?
Non-medical indications.
Yes. Yes, can.
There are certain ethical, there are certain ethnicity where IUI is not allowed. So that is the only, in the absence of medical risk, contraindications are based on the sense of ethics.
Single woman, where single woman,
Right.
Single woman, same sex female couples who
Right.
wants.
So you need to.
Some religious or social reasons can be there.
Sir,
Yes.
patients of vaginismus and some
Vaginismus
people don't.
Preference for less invasive.
treatment.
Some patients with husbands having some cardiac disease in which they are not having frequent
Then
intercourse.
we can give it in those females also whose husbands are HIV positive and the wives are
Seropositive.
negative.
Very right. Very rightly said. So, which couples benefit is unexplained infertility, mild to moderate, endometriosis, minimal, that is grade 1 or 2. Exclusion criteria, if there are blocked tubes, semen count less than 10 million, less than 20% motile. And basic steps are minimal stimulation of the ovaries, follicular study, trigger, and then IUI can be done. So how we can optimize the outcome of IUI? Selection should be good stimulation, monitoring, processing of semen sample, and then we should give luteal phase support. So coming to Dr. Shilpa Dodani, what is your experience about IUI in unexplained infertility cases?
So we feel that IUI works better in those patients in which you can't find, because there can be a thick mucus, cervical mucus, which could be the reason that the couple is not conceiving. So in these patients with unexplained infertility, IUI works well. The only thing is we have to confirm that the tubes are patent.
Rightly said, all the parameters are normal. So these are the 15% couple who have unexplained infertility. In spite of all male, female, and combined factors, they are not conceiving. So the Cochrane review says that it didn't find conclusive evidence of difference of live birth or multiple pregnancy in most of the comparison for couples with unexplained subfertility treated with IUI or when compared with the time intercourse. But no doubt, the treatment when given IVF, there are good indications and the success rate of IVF are more. So per cycle pregnancy rate for CC IUI is 7%, FSH IUI 9%, and IVF rate 30% in unexplained infertility phase. So now coming again to Dr. Rekha, age and poor ovarian reserve. So you find that her AMH is below 1, it is 0.9, just below the optimal level. What prognosis you are going to give her for IUI, or are you going to go directly for IVF?
So in this case, prognosis is poor for IUI.
Right? So age more than 35, AMH less, the prognosis is?
We go for IVF.
Right. Advanced maternal age more than 35 is the most important factor.
Yes.
Fertility and fecundity rate goes on decreasing as age increases, and woman's age is the most important factor and direct correlation with the probability of the success of IUI. And these are few studies where it is said that age around 40, number of IUI done is 4.7% live birth, 43 to 44, 1.2%, and more than 40 is 0%. So almost less success after 40 years of age and doing a IUI. But that doesn't stand true for IVF. The IVF success rate are 5 times more if age is less than 35, 4 times more if age is between 35 to 37, 3 times more if age is 38 to 40%, and 3 times more if age is more than 40%. Now coming to Dr. Ritika ma'am, which ovarian stimulation protocol to choose before IUI? Dr. Ritika Mat. Dr. Ishrat Zubair ma'am, you can take this question. Yes, please.
Dr. Padma has joined.
Yeah, we can go.
Padma Shikla.
Yes, sir. We can go for oral ovarian stimulation by oral agents.
Oral oral agents like CC or letrozole.
Letrozole, yeah.
Yes.
Follow with the and we can plan for IUI then.
What is the role of HMG or FSS cycles, madam?
Sir, HMG or FSS cycle, they are costly, and with the studies, they have been found that it is not, the results are similar. They are not significantly better than the normal oral stimulating agents. So it's better to go with the oral agents because the therapy will be cheaper, and the results are similar. So it's better to go for oral agents.
Dr. Monica Singh is expert. You agree with this, madam?
No, actually, Padma, whenever we use oral ovulagens, the pregnancy rates are significantly less as compared to the use of gonadotropins, to the extent that gonadotropins are supposed to have the highest pregnancy rate per IUI cycle, to the extent of 18 to 20%.
20%, yeah.
And
And with oral, it is around 7 to 8%
10%.
only. So
When
it's
you
3 times more.
oral ovulagens and gonadotropins, when combined, they will have something in between the two.
Yes. So our expert has rightly guided that oral ovulagens, though less costly or cheaper, it is for IUI, you are supposed to use the gonadotropins. Only problem with the HMG or FSS cycle may be chances of multiple pregnancy and sometimes OHSS. So that you have to be careful. So this audit was done where it has been found that the endometrial thickness should be between 9 to 11 mm. Now, I think Dr. Rekha Singhal has joined. So, welcome Dr. Rekha from Rewa. What are the techniques of semen washing you use in your clinical practice, madam?
Sorry, sir.
Dr. Shilpa Dodani, you can take this, ma'am. Dr. Shilpa is there, no? Dr.
Sir, he had
Ishrat.
just left.
Yes, sir. Sir, basically we use swim up and density gradient.
Yes, Dr.
these two.
Ishrat Zubair, ma'am. Yeah.
For IUI, we are using mostly density gradient, and for a very good sample, we use swim up.
Okay, so now our expert will come here again, Dr. Monica, ma'am.
Yes, sir.
So when you are going to go for a density gradient and when you are going to use swim up?
Swim up and simple semen wash and swim up techniques are used for normozoospermic cases, where
Right.
you do not have asthenozoospermia, you do have normal motility, normal count, relatively less abnormal forms, also no risk of infection. But wherever you find oats, you find oligozoospermia, asthenozoospermia, you want to keep that that sample infection free, especially where you want to do IVF with that sample. And you have got, you want, and one social indication, Kalyan sir, is also when you have less time. Sometimes the density gradient sample is prepared so the patient is in a hurry, or patient has got a train or a flight, and you have to free her within 1 hour, 1.5 hours. Density gradient will give you that. The only thing is the cost goes up. So otherwise,
Yes.
if cost is not the matter, then density gradient sample is one of the best semen samples you can get for IUI. But having said that, it has got definite indications, and simple semen wash and swim up technique is the time tested technique for normal cases, sir.
So almost in my clinical practice, I use around 80% as swim up and 20% as density gradient, because there is stringent criteria of count more than 10 million, motility more than 20 ml, 20% is followed, and rest all patients go for IVF practice in my clinical scenario. So for everyone, points to follow: prepare by a good andrologist or junior embryologist, use Mackler's chamber for analysis, incubation at 37 degrees for 30 to 40 minutes For capacitation of the sperm, IUI to be done within 1 hour of washing. If it is getting delayed, keep in a chamber where temperature is 37 degree. Long distance traveling of the sample to be avoided. And new ART law says that you have to mention the pathology labs about this timing. And nowadays, only ART centers are doing all IUI preparation. Level 1 ART centers are doing. So don't send to a pathologist which is not registered with the ART center. And IUI by trained personnel with due precaution. Now coming to the, yes, ma'am, Dr. Monica, ma'am, you can add.
Just one tip for the new practitioners and for gynecologists who are planning to have level 1 clinic. There is a formula of 90 minutes. The semen collection to insemination time. If we stick to about 80 to 90 minutes, that gives you the best results. This includes the collection, the liquefaction, the simple semen wash, the centrifugation, pellet, then you aspirate and do the insemination. The message is there should be minimum time between loading the prepared semen sample into the cannula and insemination. I think that gives you wonderful results.
Very rightly said. Now coming to Dr. Padma Shukla, madam.
Yes, sir.
What is the timing of doing a IUI? You are doing a follicular monitoring. You find that it has ruptured. So what is the timing you are going to follow?
Sir, it is a single IUI which is recommended, and usually we can do the IUI when we give the trigger of HCG. So 0 to 36 hours, I mean between 0 to 36 hours. So near to 36 hours we can do.
So it is Doctor, I'm coming to Dr. Desh Deepak sir. He's available? Dr. Desh Deepak sir?
He is there.
Yes, but he's
Yes,
Yes,
he
sir.
has not named himself. He has joined with iPhone.
Yes, Dr. Desh sir. So you believe in doing doing single or double IUI?
Sir, double IUI, the success rate is good, but nowadays we are doing single IUI just 36 hours after giving the HCG injection. Normally, evening में या night में 10 p.m. We give the HCG injection for trigger, or sometime if it is a multiple follicle, then we also give the decapeptyl also. If there is multiple follicle, then in the morning we plan the IUI 36 hours. मतलब say for example परसों आज नाइट में इंजेक्शन दिया 10 बजे तो परसों मॉर्निंग में IUI करते हैं.
So there are two. One is a fixed protocol where in single insemination 30 post SCG, and variable protocol is TVS 36 hour post SCG ovulated single IUI, not ovulated IUI once, and IUI after 24 hours later. So now coming again to Dr. Ishrat Zubair about the number of inseminations, whether single or double, and what you are doing in your clinical practice.
Sir, I do only single IUI. I don't do double IUI. I don't find it very useful in my practice, so I am doing only single IUI.
Very rightly said, single versus double. This Cochrane study has said that based on the results of pregnancy rate per couple in 5 trials, double IUI resulted in significant benefit over single IUI. But nice guideline, according to Dr. Ishrat, intrauterine insemination is undertaken single there rather than double insemination should be offered. That is nice guideline what Dr. Ishrat Zubair has. Now, you have started this treatment, Dr. Ishrat. So how many total IUI you are going to do in her whole lifetime for conceiving?
Sir, my funda is I won't do more than 3 IUI. After 3 IUI, if they fail, I'll go for IVF.
Okay. So now our expert, Dr. Monica Singh, will answer about how many IUI per patient for single pregnancy.
So this has to be individualized again. Dr. Ishrat, you are right in mentioning the figure of 3, though I would stretch it to 4. 3 to 4 is the optimum number when you are likely to get the maximum results. The graph
Depending
and the
on age
percentage
also.
of success keeps increasing till 3 to 4 IUI, then it plateaus in 3rd, 4th, 5th IUI, then it comes down. The maximum number of IUIs in literature have been up to 9 to 12 also, and a little bit of benefit of extra 1 or 2 or 3 cycles of IUI can be given to male factor IUI and to donor insemination cases. In donor insemination cases, you can even go for, something like 6, 7 IUI till she conceives if she's got patent tubes, because you don't want to do IVF for that patient with patent tubes and good endometrium and good ovulation. Having said that, the best chances of success remain to be 3 to 4 IUI cycles.
Very rightly said. Dr. Ritika has joined.
Yes, sir, I'm there, but I'm having some problem with my set.
Okay, you
Yes, sir.
stop the video and just talk to us on audio. You
Yes,
give
sir. Yes, sir.
face support for all.
So it's I give luteal support for maximum, sir. But sometimes progesterone, sir, it does not help everyone now. So I personally I give it to all.
Okay,
Sir.
so it is documented that all HMG cycles you should give a progesterone support.
Yes, sir.
And for patients with CC, it may not be benefit.
Yes, sir.
Factors affecting IUI results are sperm quality, causes of infertility, age being important factor, response to ovulation induction, lab quality, and IUI sample processing and technique, and luteal phase support in GnRH cycles. Now coming to the second case, a 30-year-old lady has amenorrhea unless administered progesterone. She only bleeds on progesterone withdrawal. Her BMI is 29. Sonography shows PCOM. Husband has normal parameters. They've been trying to conceive since 3 years. Previous history includes 1 anovulatory cycle of CC50 and 2 ovulatory cycles with letrozole 5 mg. So now my question, what oral health intervention would you like to discuss with the couple at this age before starting any of the treatment? So coming to Dr. Padma Shukla, madam.
Sir, I would like to ask the patient to improve her lifestyle and to reduce weight at least 5 to 10% of her body weight. And she has to do the regular exercise, at least 150 minutes per week of moderate exercise she should do to optimize her health.
So lifestyle modification is very important. There can be a metabolic, we can consider checking her sugars, BP, diet and activity, and rightly said about mental health. She should do a lot of good diet habits. 10% weight loss is mandatory. There is no PCOS diet which has been given by a few companies. A sustained calorie deficit of 30% is needed to reduce the weight, and rightly said by madam, 150 minutes per week of moderate intensity exercise like going to gym, doing a Zumba classes, or doing some good exercises at home also is going to be very important for these patients. Now coming to Dr. Rekha Singhal, madam,
Yes,
which
sir.
metabolic parameters you are going to assess for this?
Sir, GTT, glucose intolerance, lipid profile, thyroid profile,
Rightly said.
prolactin.
So day 2 hormones, AMH level, serum insulin, OGTT, and then you're going to rule out all these metabolic diseases and going to guide her accordingly because they cause anovulation and insulin resistance, and fasting glucose to insulin ratio should be less than 4.5, which will be insulin resistance. So you are going to assess her, give her good dietary habits. Now coming to Dr. Ishrat Zubair madam, after lot of efforts from Dr. Rekha and Ritika Mathur, she has lost some weight. Periods are irregular but spontaneous. 6 months have passed. Her AMH is now 5.1. Would you prescribe non-ovulsions or any adjuvants to her? And if yes, what is the choice of the drug?
Yes, sir, definitely. I would like to prescribe supplements like in PCOS patient, her AMH is high. I would like to prefer metformin as a adjuvant because it corrects the it increases the chances of spontaneous ovulation also, and it corrects the menstrual irregularities also. Then we can plan further ovulations for next 2 or 3 cycles after that.
Very rightly said. Dr. Monica Singh, you want to add any other drugs apart from metformin?
Yes, nowadays, sir, inositol has also come into the picture, and
Right.
pharma companies are now coming with the combinations of metformin and inositol. So the mechanism of action of both of this is different, though inositol is a slightly costlier product, but we find in the younger patients some good results with inositol. But
What is the ratio you are maintaining MCI to DCI?
sir, it is 1:40, I think.
40, right?
1:40, yeah, and it is well tolerated as compared to metformin, which requires a certain, you have to gradually escalate the dose. But having said that, metformin remains my favorite also. There are so many patients who have conceived after taking metformin. And just one word of advice: if your PCO patient conceives with metformin, please do not stop the metformin after she becomes pregnant and continue, because this later on will prevent her GDM. This will keep her metabolism and everything under check, and it can be continued safely till termination of pregnancy.
Yeah, till delivery, you can safely continue.
Yes.
So now coming to Dr. Shilpa, she has joined? No? Okay, again coming to Dr. Padma Shukla. What fertility care options you want to discuss couple once she has lost the weight? Which
So,
drug? Yes.
I would like to give her oral stimulation
Ovulation,
stimulation
right.
agent like letrozole, which is drug of choice of these patients, and along with metformin. So, and I will follow her up, and we can plan along with the IUI. If she
Yeah,
does.
rightly said. Yes. Firstly, she is resistant to CC as per her history. She has ovulated with letrozole 5 mg.
Yes.
We are going to continue this for how many cycles you are going to continue?
So she has already taken 2 cycles of
Yeah.
letrozole.
So
And go
another
for
2 cycles or 4 cycles?
Yes, sir. 3-4 cycle we can go for.
All right, 4 cycles you can safely give. Now coming to the when you are going to give gonadotropins for this patient, this question is for Dr. Ritika Mathur.
Sir, gonadotropins, if this does not, if you are going for an advanced procedure like IUI, IVF, then only I'll recommend, sir.
So anytime we have discussed this, success rate of IUI with gonadotropins is high.
Yes, sir.
3 times more than only ovulations. So if you are planning for gonadotropins and going for IUI, then it makes a sense. So anytime she's going for IUI, it's always
Only then
better
I'll
to go
prescribe,
for.
sir.
Now
Yeah.
coming to Dr. Padma Shukla, madam.
Yes, sir.
When are you going to go for a laparoscopic ovarian drilling?
Sir, if patient is not responding to oral medication or with gonadotropins, then we can plan for ovarian drilling.
So resistance to oral ovulations, even less response to gonadotropins, you're going to go for a Dr.
Ovarian
Deshdeep,
drilling.
sir, what is the take-home message for laparoscopic ovarian drilling?
Yes, sir. In my practice, the lean and thin PCO, they respond better in ovarian drilling. The criteria is that ovarian volume at least more than 8 ml, and the LH level should be high, and the funda of the urine dealing that funda 4, like 40 watt, 4 in number, and depend upon the size of the urine also. And we are going in with cutting current, coming out with coagulation current. So, but in our practice also, what I day by day realize that before going to the urine drilling, we are giving low dose recombinant FSH in such type of the cases. Because sometime it is individual variation. If we do more drilling, then chances of the POI also. So nowadays, before going to the drilling, we are giving low dose recombinant FSH for induction of ovulation, having good result. In cases of the PCOS who is not responding to the letrozole.
Deepak sir, I have a question. Like if we are doing a good drilling in, like as you said, in thin PCO, so like do we wait
Yes,
for spontaneous conception for 3 months, 4 months? Is there like any guideline for that, or like in personal experience also? I wanted to ask, how many months can
No,
we
madam,
wait for that
after dealing
without
and next
ovulations?
from the next month we start giving induction of ovulation.
Okay, okay.
Thank you, our expert, Dr. Desh Deepak sir. Now this patient has opted to undergo gonadotropin and IUI therapy and presents to you on day 2 of the period. And we have started her on oral ovulations and gonadotrophins. On day 8 of stimulation, there are 3 follicles of 15 millimeter in each ovary. What next you are going to plan for this patient? Dr. Padma Shukla.
Sir, as she has 3 follicles in each ovary, there are more chances of going to OHSs. So her cycle either it should be cancelled or she can be taken as IVF cycle. As per
Okay. Dr. Monica Singh, what is your experience about this?
Sorry, I was just seeing a patient about gonadotropin use.
More than 4 follicles in IUI.
IUI cycles. See, sir.
You are muted, madam.
Sorry, sir, I was just seeing a patient, but I understood the question. 3 to 4 follicles, and we proceed with trigger or not. So this is actually a tricky situation. Ideally, we should not give a trigger with more than 2 dominant follicles. But if you have experienced some IVF centers, some IUI centers, I have seen giving a trigger even with 3 dominant follicles. And let us hope that it is not triplets, and keep a good watch on the patient. But definitely more than 3 dominant follicles is a no to trigger. Then either you have got 2-3 options. Either just leave it like this, no trigger, nothing, tell the patient to abstain in that cycle. Second option is you convert it into IVF cycle, but that is also requiring a lot of counseling. And conversion of IUI to IVF cycle may have lesser pregnancy rates as compared to lesser success rates as compared to an IVF cycle, which is planned right from the beginning. And I think these are the 2 options we have.
Okay, how many times you are done conversion to IVF cycle, madam? Rescue IVF?
I have done quite a few, sir. Sir, actually, there was a time between 2010 to 2017-18, we were using IUI with Antag.
Right.
So there was a paper, many papers came out that time in ESHRE that antagonists can improve the pregnancy rates with IUI. So we started using Antag in quite a few cycles and we got good pregnancy rates, but the cost of cycle goes up. So in those cases where Antag is already given to the patient, you can very easily convert to IVF because you don't have any, fear of LH surge. And the pregnancy rates were surprisingly, Kalyan sir, they were good.
Thank you, ma'am.
Yes.
Yeah, so for everyone, take home message, have 1 or 2 your good friends who are IVF consultants. In case there is an emergency like more than 4 follicles in each ovary, you can convert this patient into low-cost IVF cycles. They will take only charges of OM pickup and ICSI and not other charges, and patient can have benefit also. So coming to our another expert, Dr. Desh Deepak sir, what is the take-home message for treatment of PCOS patient?
So in PCOS patient, in cases of the what is the lifestyle modification, your whole summary and reduction of the weight, then adding the metformin. Then in cases of the lean and thin PCOS and not responding to letrozole, as I told previously, then we are using the low dose recombinant FSH. And in other cases, when there is two follicle or three follicles, in spite of giving SCG, we can give decapeptyl, the GnRH agonist also for trigger. And suppose we were not doing rescue IVF, so if we think that there is chances of hyperstimulation, then we can add the cabergoline continuously as we are adding in IVF also. So there is
Okay, so if you give decapeptyl, won't it hamper the endometrial lining?
yes, sir, it will hamper the endometrial lining. Then we can give support also in such cases. And our patients conceived also after doing the even after ovulation. If you see endometrium, there is some shrinkage of the endometrium always, even after normal ovulation also.
Okay, sir.
And sometimes we can give dual stimulation also, sir, like IVF using decapeptyl plus low dose SCG. So that also in IUI also we can also give. Even in IUI we are using antagonists sometimes. Suppose if we are going out conference in the Sunday, so we can postpone also. So we can use the GnRH antagonist also in such cases where there is early rupture of the follicle. So
where you are suspecting early rupture.
just like in IVF.
Like any time the follicle size is more than 15 millimeter, you can start and time the IUI accordingly. If in case you are
Yes, sir.
giving Upride depot or decapeptyl, then you need to give the luteal phase support that is mandatory for such patients. Thank you, sir.
Yes, sir.
Thank you, the experts. Now coming to Dr. Padma Shukla, a 33-year-old lady, and her husband are in consulting room with 5 years of trying time. The man has normal semen analysis. This HSG they have come up. They have been advised IVF for this patient. What is your opinion and how you are going to counsel this patient?
Sir, seeing the picture of HSG, it looks like it could be tuberculosis as well. So I would counsel them regarding this tubal factor and about ATT as well. And we can, after ATT, we can again see her tubes and we can advise her accordingly. Moreover, she has to go ART, but sir, I have experienced that the patient with who are having tuberculosis, they respond very well after ATT.
Dr. Rekha Singhal, I'll come to you, sir. Just wait. Dr. Rekha Singhal, ma'am, are you agreeing with this?
Yes, sir. This is the case of, I think, hydrosalpinx.
Yes.
And most common etiology is tuberculosis. And ATT we have to give.
Now our expert will come into the play. Dr. Desh Deepak, sir. Dr. Desh Deepak, sir. No. Dr. Monica Singh, ma'am.
Yes,
This
sir.
is a picture of HSG where some of our panelists are saying to give AKT directly. Do you agree with this or you have some other plans?
So a retort-shaped HSG of this manner with the left tube also showing loculations, outpouching of the tube, spill. HSG is actually one of my most favorite investigations. If we get a definite indication and history suggestive of genital cox, then the latest guidelines, as per Professor J.B. Sharma sir was there in the last webinar, He has said that any finding of suggestive of genital cocks on HSG, on laparoscopy, on hysteroscopy, on MRI, you can start AKT, explaining in your paper that why have you started, provided there is also some clinical evidence to that effect. Because PCR, all those tests and the BACTEC test and the gold standard test, all the expensive tests being done in the laboratories, all of them have got a lot of false negative and false positive, sir. So, sir, with this report, if the patient also has got some clinical history of contact, like just now, 2 or 3 days back, I got exactly this HSG picture in my OPD, and this patient was looking very lean and thin. I probed her, I kept on probing her. She then said that after 1 year of marriage, in her house, they lived in a 2 or 3 room house, there was elder brother of her husband who died of pulmonary tuberculosis. So she used to cook for all of them. They lived in the same premises. So I put to, and then she had a persistently thin endometrium after that. She stopped having regular periods. She had scanty menses, infertility, blocked. So if such findings are there, then we should not waste time in CBNAT or PCR, and we can put our findings on a consultation paper and give AKT directly according to the Nikshay Yojana of government. And we have
And
to
it is
inform.
very important that if your clinical suspicion and your history is suggestive of that, you can very well start without any of the lab investigations. But it is mandatory to inform to the government that you are starting the AKT. It is a notifiable disease.
Yes.
So anytime a clinician can start if she has a lot of suspicion with some of the history suggestive of this. Now that is one part. We have done the HHG. Again, after 6 months, she come to you with a similar picture. So, are you going to go for a surgical removal or directly go for a IVF? What are the options, Dr. Deshdeepak sir?
Sir, we will go for surgical removal because in IVF also, if there is hydrosulfings, then there is more chances of even ectopic pregnancy, and we will get less success with such a hydrosulfings tubes. So before planning embryo transfer, we should remove such type of the hydrosulfings. Any hydrosulfings detected in sonography should be removed, detectable.
Any hydrosulfide more than 2.5 centimeter needs either clipping or removal of the tube. If you are going to remove the tube, because these are infertile patients, the blood supply of the ovary has to be preserved nicely. You have to be judicious enough that you are not hampering the ovarian blood supply. So,
Yes.
what is your experience, expert Dr. Deshdeepak sir, with the ovarian reserve of such patients with tuberculosis? Indian scenario.
Sir, what I have seen many times that is such type of the tubes are badly adherent to the ovary, and they make like just like it mass also. So sometimes it is very important to gently separate such fallopian tube from the ovary, and if we are doing self-injectomy, then we should uh, away from the ovary and use the harmonic scalpel. Don't use the bipolar if we are doing self-injectomy, because in clipping also sometime when we do the pickup, because sometime I have seen this type of the fallopian tube just engulf the ovary also. So there is more chances when you doing the pickup, then you can go for hydrosulfing to the ovary.
Now, my
So it is better
experience is
to.
that in India, AMH levels are low in the patient where there is a genital cause.
Yes, sir. Yes, sir. That is also true.
So now coming to our expert, Dr. Monica Singh, she's going to explain us in 10 lines about the tubal factor infertility and its management from IUI to IVF.
Sir, tubal factor infertility, naturally, when it comes in a clinical scenario in India, the first thing we think about is tuberculosis. So if you have a tubal factor due to tuberculosis, please treat start AKT if she is not already taken. Some patients are nowadays very intelligent. They're coming with clear-cut history that I've taken AKT properly, and they have documents, they have the government card, it's okay. So, sir, bilateral tubal block, tubal factor, you have clipped the hydrosalpinx, you put the scope, you've started AKT, you're satisfied, everything is okay. This patient is a clear case for IVF because you should not waste time on unhealthy tubes. I tell the patient where I see on HSG one side hydrosalpinx, the other side minimal spill, loculated spill. That spill should be like a waterfall, cascading. If the spill is loculated or something, you think it is, you cannot call it a patent tube. And then you try to push more dye, you try to do more chromoperturbation. But this patient can land up with an ectopic pregnancy, and it's very unlikely she will land up with a normal gestation through IUI or normal conception. So these cases, young cases, treated cases, after clipping of hydrosalpinx, they give excellent results by IVF. And you catch them early so that the ovarian reserve, like Kalyan sir just said, is not compromised. The good thing about tuberculosis is that it will first go to the endoluminal region of the fallopian tubes, the cilia, the mucosa, then it travels to the endometrium. So endometrium is affected next. Third and fourth, it will go to the cervix, vagina, and ovaries. So the tuberculosis has got some effect of sparing the ovary if you catch it early. But if you catch the patient after 3-4 years of infection, especially if the patient has got a failing physical health, then she will have poor ovarian reserve. She will develop all the stigmata of TO masses and everything, which is difficult to treat. So, sir,
Right.
they have got good results with IVF. We follow normal protocols for them.
Thank you, our expert, Dr. Monica Singh, madam. Now coming to everyone, a single question, last question. Dr. Rekha ji, when are you going to go for IVF? After how many IUI failures?
So 3 to 4.
4 IUI. Dr. Padma Shukla?
Sir, after six, sorry, sir, I'm Ritika. After 6 failures, sir. 6 IUI failures. 6.
6. So, Dr. Ishrat? Zubair, madam?
Sir, it is very much individualized for me. Like if it is a male factor mostly, so we can go for up till maximum 4. But like the patient age, AMH, other things we consider, I used to do maximum 3. This is my personal thing. I never do more than 3.
Right. Dr. Ritika?
Sir, for 6. I'll try for 6 IUI cycles. After that, I'll go for an IVF. And again, it is an individualization of case as well, sir.
Thank you. Now, coming to Dr. Monica Singh, when are you going to go for a IVF in general? What are the indications of going to IVF ICSI? A patient is on a IUI cycle or not on IUI cycle. What are the indications of doing a IVF?
Sir, here also because I love to do my IUI cycles. I've got a very, I will not like to be here boast about it, but I have got some of the best IUI results in Madhya Pradesh because I persist with my IUI cycles in a very scientific way. This patient comes and she has just done CC Letro cycles. Then you can give her 3 cycles of oral ovulation plus gonadotropin, at least 1 or 2 cycles of gonadotropin, and then say that she has got 4 good IUI cycles. The magic figure is 3 to 4, and this is not what I am saying. It is what is written in literature in evidence-based studies that the best escalating results are with 3 to 4 well-timed, well-performed IUI cycles in good IUI clinics. And another thing is male factor, sir. Male factor, mild to moderate endometriosis, you can increase the attempt by 1 or 2 cycles, especially if age is less than 32, 33 or something. Once you reach the watershed line of 34, 35, 36, you again think and consider you come to the fast trial, which Kalyan sir has showed us. Rain Dollar study says that after 35 years, instead of wasting time on 4 or 5 IUI, you will be better off doing an IVF cycle, but that was for unexplained infertility. Now, sir, you are a famous laparoscopic surgeon, Kalyan sir. Unexplained infertility has again come under the scanner because you put the scope, you scope the patient, you will
There is
sometimes
endometriosis.
find lesions which explain that unexplained infertility. Then one panelist said something about thick cervical mucus, I think Shilpa. Shilpa, there is nothing called a thick cervical mucus. This is all physiology. There is nothing called anti-sperm antibody, nothing. Whatever antibodies we are studying in the cervical canal and uterine cavity, they are very different from the peripheral antibodies which we study in the blood. So all these immunological tests, antibodies, again, they are big question mark whether you should do or not. That is why we have stopped testing them. Cervical mucus is such a thing which changes along with the physiology of the body. In ovulation, it has to become thin. After ovulation, it has to become thick. So, sir, this is my entire
Now coming
summary.
to our second expert, Dr. Dev Deepak sir. Can you just start your audio and video, sir? Yes, sir. Dr. Dev sir. Now, what are the indications of ICSI in male factor and how you are going to go about this?
Sir, it depends upon the semen analysis parameter. And if the count is less than in IUI, we are using more than 5 and less than 5 million. And depends upon the age also, patient and female factor also. If the age of the female is more, then also we are planning the HC.
We are talking about
And
only male factor.
okay. In male factor count
Severe oligoasteroideozoospermia.
severe oligoasteroideozoospermia more less than 5 million. Motility is less. And azoospermia, obstructive azoospermia. And
now my question to you.
In failed IVF cycle also.
Right, 4 IVF. Oh, sir, you do DNA fragment.
Even in cases of the recurrent pregnancy losses also, recurrent pregnancy loss also in DFI, when the DFI is more, in those cases also we can plan IMSI also.
So
morphologically selected
DFI for all the patients who are undergoing IVF?
DFI?
Yes, sir.
Yes, sir. Nowadays we should do in all cases going for the IVF because in IVF also if we face the recurrent pregnancy losses. There is history of recurrent pregnancy losses. So in WHO also they are recommend now we should do IDFI before planning IVF.
You are doing it.
Semen analysis with morphology and DFI.
Okay, we practice only in poor morphology patients, but right, you can do it because as such patient is spending so a lot of money and around 3,000 rupees is not a big deal for the patient, right? It is going to give us a good embryo, euploid embryo, that is the advantage.
Because suppose if there is blighted ovum or some, because in all cases we are not doing the PGD or PGS. So then patient is asking, sir, ऐसा क्यों हो गया कि मिस्टर बॉल्सन में क्यों चला गया, क्या जवाब दो? फिर अपन बाद में DFI कराते हैं, उसमें ज्यादा आता है, तो फिर बोलता वो सोचेगा कि पहले क्यों नहीं कराया, फिर इतना बड़ा टेस्ट नहीं था. Maybe.
Okay, now last question, Dr. Monica Singh. One take-home message for optimizing IVF result.
My take-home message is that proper case selection and ethical practice, wherever required, where the patient needs IUI, can benefit from IUI, please do IUI, give a fair trial. Never hesitate from putting a scope wherever you feel it is indicated, but don't do in unindicated cases. Hysteroscopy now is as good as a 3D TVS. In fact, a 3D TVS has become so good and reliable. It is as good
like hysteroscope.
It is in the convenience of your chamber. So wherever, yesterday we had a terrific panel, sir, where our moderator told us that you can find out genital cocks from the interstitial image of the fallopian tube on 3D. And she showed us a series of images where the interstitial portion of the tube becomes like this, 2 vertical lines in genital cocks. So use your technology to the best advantage of the patient. we have to try to save money for the patient. I feel if you save money for the patient, she can probably afford one more good cycle with you.
What is the role of endometrial scratching?
You're asking me, sir?
Yes, ma'am.
Sir, endometrial scratching, again, after Sunkara's paper came in ESHRE, we used to do lot of scratching, every case, not with a curate, but we used to basically
IUF.
take the
IUF.
hysteroscope and pipple or something like that. But again, now there is no evidence that scratching leads to better implantation. But pre-IVF hysteroscopy, which some people say improves result, may be due to 2-3 reasons. Number one, cervical dilatation. Number two, that you are imaging the inside of the uterine cavity. You're causing very subtle adhesiolysis, and you are causing the capillaries to bring in more blood to the endometrium, give a better endometrium after pre-IVF hysteroscopy. But again, it is up to individual clinic. And there is a fourth level of evidence, which is known as grade 4 evidence. Grade 4 evidence means Dr. Kalyan's evidence, Dr. Desh evidence, Dr. Monica Gupta evidence, Dr. Monica Singh evidence. This evidence has got lowest importance in a conference hall, but this has got great importance for us because we trust it. This we can share in closed platforms like this, but we cannot tell that Padma and Rekha and Ishrat, please do this because I am doing it. They have to adopt according to their clientage, their scenario, their experience, and the budget of their patients.
Thank you, ma'am, for your expert opinion. I thank Dr. Deshdeepak sir, Dr. Monica Singh ma'am, Dr. Padma Shukla madam, Dr. Rekha madam, Dr. Ritika Mathur madam, Dr. Ishrat Zubair madam, and Dr. Shilpa Dodani, who was there for some time, for excellent discussion about this. And I thank Dr. Monica Umardand for giving me a lot of help for arranging this eco webinar series. And now I hand over to Dr. Monica for vote of thanks.
Sir, I must
Thank you, sir.
congratulate you for excellent panel. I have never heard such a good and practical IUI panel in my whole life.
No, we had skipped the question of IVF because I got a message that most of them are doing only IUI. So
Yes, sir.
Yes.
Thank
Very
you,
right,
ma'am.
sir.
Thank you, sir, for the opportunity to coordinate and convene this webinar. Thank you, Sunita ma'am, PK Shah sir, and Kavita ma'am for gracing the inauguration. The chairpersons, Patidar sir and Meena ma'am sir could not join us today due to emergency, but Taru madam had given us an excellent and elaborate talk on micronutrients in pregnancy. Our moderator, Kalyan sir, has kept the panel very, very crisp and has given us a lot of take-home messages by our experts, Dr. Deepak sir and Dr. Monica Singh ma'am. Thank you, our panelists, Shabana ma'am, Dr. Purnima Tiwari madam, Dr. Padma Shukla ma'am, Dr. Rekha Singhal, Dr. Ritika Mathur, Dr. Ishrat Zubair ma'am, Dr. Shilpa Dodani, and Dr. Nidhi Bartunia. I also would like to thank Dr. Monica Gupta madam as the coordinator for the West Zone series of ECHO webinars, and Team Corona and Nilesh Darji for the academic assistance.
And Dr.
And the
Monica
technical-
Umardand for the nice convening of all the webinar series.
The boss now. And all the best, Dr. Monica Singh, madam, for your upcoming elections.
And I request all the societies to please nominate and vote for Kalyan Baramde sir as Vice President FOXI, and also support the candidature of Dr. Monica Singh ma'am
Thank you.
for the
Thank you so
infertility committee. Thank you.
Thank you for your
Thank
kind
you.
regards.
Thank you so
Thank
much.
Kalyan sir, all the best.
देश दीपक
Thank you,
सर
sir.
दिलवाएंगे
Full
कोटा
sir.
का वोट तो सर
अरे कल्याण सर को फुल सपोर्ट है.
Kalyan sir is already a winner.
देशदीपक सर
Already
के
a
पैरों
winner,
में
sir.
बैठेंगे हम.
हाँ,
अरे
कल्याण
सर
सर देश
कैसी
दीपक
बात
सर को
करते
पकड़ लो,
हो
आप राजस्थान के तो सब मिल जाएंगे आपको वोट
हमें पता है वो क्या चीज है.
सर, मुझे भी आशीर्वाद दे दीजिए देश
अरे
दीपक।
नहीं सर आप तो
नहीं नहीं, मोनिका
हमारे
दिलवाएंगे,
ISG
आपको
के
भी दिलवाएंगे।
प्रेसिडेंट
हाँ,
सर
सब
आपके बारे में.
सर से।
Can you stop recording, please? Stop recording.